Hi, I'm Jennifer Robom. I'm a behavioral science faculty for the Family Medicine Residency of Western Montana. This isn't working very well. It's my pleasure this morning to introduce Patrick Davis. He's a licensed clinical psychologist who used to work at, thank you, oh, that's too high, at the Montana Spine and Pain Center over at St. Patrick Hospital. He was there for over 8 years, directing the pain school program, and he's recently left them to go into private practice where he specializes in chronic pain and forensic psychology, among other things. Patrick, welcome.
Thanks, Jen. I'm going to try to get this other microphone going here. Hello, everyone. Get this out of the way if I can a little bit. It sounds pretty loud to me. Can you hear me in the back? Thumbs up? Yeah? Okay. I tend to have a fairly resonant voice. Geez, I'm pleased to be here today. I want to thank Dr. Mentel and the rest of the planning committee for putting this thing together. As we can see from the banner here, the Montana Pain Initiative conference has been an ongoing thing for quite a while now, and I've had the pleasure of attending and even presenting at many of these conferences. And I was particularly gratified listening to the presentations that came before me this morning to find out how much we're really on the same page these days in terms of the focus on the neuroscientific approach to helping people learn to better manage the pain that's created by their brain. And that's really what I'm going to be talking about today. A couple of years ago, I did a couple of presentations at this conference. One was on, the title was How Exactly Are Nerves Plastic? And I think that's the title that was put into the program for today. And that is going to be the bulk of what I'm going to talk about today. But 2 years ago, I also talked about how behavioral therapists or behavioral health practitioners work with chronic pain as well. And they had, in some of our discussions in the run-up to today's presentation, I was asked to fold that in to the presentation as well. So that was a little bit of a challenge because that's 2 previous presentations that I've done that were easily an hour each in the past that I tried to kind of combine into one for today. So mostly I'm going to focus on this idea of neuroplasticity and what exactly are the actual mechanisms of neuroplasticity. Let's see, Dr. Schneider and Dr. Lancaster both talked about the importance of working with people from the perspective of a neuroscientifically informed approach to understanding pain. And Christian Apple also talked about his education of his patients with regard to the neuroscience and talked a bit about the explained pain model. And so what I'm going to do is I'm going to dig a little bit deeper. I think it's really very valuable to try to persuade patients or clients about this idea that pain is a phenomena that's created by their brain, which, as Lindsay pointed out, does not mean that it's imagined or that it's all in the mind, but rather it's a very real phenomena that people experience, and we're gaining a lot of insight into how certain changes in the nervous system can contribute to this experience of pain, even in the absence of obvious tissue pathology. So we're going to look at a number of the mechanisms of neuroplasticity that contribute to that. When I talk with a patient about that and try to persuade them that the nervous system is plastic and that it can actually change in such a way that pain becomes a learned experience, I think it's really helpful to actually be able to dig a little bit deeper and show them some pictures or give them some descriptions or maybe tell them some metaphors that explain exactly how this neuroplastic thing happens, because it really kind of sounds a little bit like science fiction or fantasy when you talk about it. But there's actually a great deal of basic research that has been done over the last 30 or 40 years, I guess now, that has helped to elucidate a lot of these fundamental physiological mechanisms that underlie this concept of neuroplasticity. So we're going to look at a great deal of that today. Let me see if I can figure out how to operate this thing. That's not the right button. Which button do I push to advance the... Oh, that one. Oh, I was trying to go backwards. I had it upside down. My name is Patrick Davis, and I approve this message. Okay, so let's talk talk about a little bit, just very generally, what is neuroplasticity? So we know some of the definitional elements of this concept of neuroplasticity are displayed here. It's a change in the structure of neurons in response to experience, or a change in their function, change in their organization. So their actual structure may change. The way they communicate with other neurons may change, and the way that they're organized in groups of neurons may change. These are very basic elements of neuroplasticity. We also see strengthening or weakening of neuronal connections, and the adding of new synaptic connections, or even now we know, sometimes new nerve growth, neurogenesis. With regard to this issue of neurogenesis, you know, when I was going to graduate school, we were told that you never grew a new nerve cell. It's a relatively new science, this idea that we can grow new nerve cells. But we do know, well, back in 1962, actually, Joseph Altman demonstrated evidence of adult neurogenesis in humans, but he was pretty much ignored, and it wasn't until the 1980s or even the 1990s when animal models started demonstrating that this was really true that people got on board with this idea. Well, we now know that in the lateral ventricles and also in certain areas of the hippocampus, there is ongoing neurogenesis throughout life, including during our adult years for adult humans. So that's pretty exciting. That was one of the, I think, maybe most important and most impressive findings that has to do with this idea of neuroplasticity. We can actually grow new nerve cells. And one of the really interesting things, as we'll see about chronic pain, is especially with regard to this neurogenesis in the hippocampal area, is there appears to be a dampening down of this genetic growth, or this neurogenesis in the hippocampus among people who have chronic pain. And so that has implications for their ability to learn and their ability to cultivate new pain-related and other kinds of memories. Anyway, I'm getting the cart a little bit ahead of the horse here. I want to take you on a little walk through a hall of fame, you might say, in terms of some important figures in the history of neuroplasticity, since we're talking about what exactly is this neuroplasticity thing. And so since I am a psychologist, I was very pleased to discover that one of the first people we talk about when we look at the history of neuropsychology is this fellow named William James. Now, he was not only the first educator to offer a psychology class in the United States and a leading intellectual in the late 19th century, and believed by many to be one of the most influential philosophers the United States has ever produced, and described as the father of American psychology. But he's also credited with being the first intellectual to suggest that the brain's capable of reorganizing itself. In his words, he said, "Nerve currents propagate themselves easiest through those tracts of conduction which have been already most in use. So nothing is easier than to imagine how, when a current once traversed a path, it should traverse it more readily still the second time." And so for saying things like that in the book, the text he published, the Principles of Psychology in 1890, he has been credited, at least by some, as kind of the first thinker, at least in American history, to really talk about this idea of neuroplasticity. Another important historical figure is Jerry Konorski, who was a Polish neurophysiologist. And he coined the terms neuroplasticity and synaptic plasticity. In 1948, he suggested that over time, neurons that had coincidental activation due to their vicinity to a firing neuron would, after time, create plastic changes in the brain. So he did not coin the term, "if you fire it, you wire it." But I think the work that he illustrated really set the stage for that phrase that we do sometimes use now with our patients. If you fire it, you wire it. The next important figure I want to mention is Donald Hebb. He's probably a bit more well-known. He is a Canadian psychologist who articulated the idea that neurons that fire together, wire together. This is another one of those little neuroscientific maxims we hear. Again, he did not coin this phrase. The coining of the phrase actually was cells that fire together, wire together. And that was attributed to Carla Schatz in the context of her summarization of Hebb's work in a 1992 article that she published in Scientific American. What Hebb actually said is what's written on the slide here, or the image. When an axon of cell A is near enough to excite cell B, and repeatedly or persistently takes part in firing it, some growth process or metabolic change takes place in one or both cells, such that A's efficiency, as one of the cells firing B, is increased. Another notable historical figure in the history of neuroplasticity is Paul Bach-y-Rita. I hope I'm saying his name correctly. He's the first neuroscientist known to have developed clinical applications relying on the capacity of the nervous system to make neuroplastic changes. And if you guys will bear with me for just a minute, I realize I'm tethered to this thing, and I think I'd feel a little freer if I had this attached to my belt. So this fella is Paul Bach-y-Rita. That's how I would say his name. I'm not sure if that's how you pronounce it or not. But he was the first neuroscientist who's been credited with developing clinical applications based on neuroplastic theory. So you can see so far we're not really talking about neuroplasticity and pain, but we're going to move into the applications of neuroplasticity to pain here in just a few minutes, kind of getting some general background first. Bach-y-Rita's father had a stroke which caused some fairly significant physical and language impairments. And him being a neuroscientist, he thought he knew enough about how the brain worked that it seemed reasonable to him that healthy areas of his father's brain should be able to take over these lost functions that were lost due to damage because of the stroke. And so he put together an exercise program for his father and actually was successful in helping his father to almost make a full recovery with regard to the impairments that he had both in language and motor function. And he went on to develop a couple of other treatment programs for people who had other types of impairments associated with brain damage. So these are some of the notable figures in the history of this thing we call neuroplasticity. Perhaps the most widely known figure in the field of neuroplasticity, and the person who's really done the most to raise the consciousness of the general public about this thing that we call neuroplasticity, is Norman Doig. Show of hands, how many people are familiar with Norman Doig? Really, not that many. Okay, well, I'm glad that I'm introducing him to the rest of you. Back in 2007, he published a book called The Brain That Changes Itself, which, along with the Explain Pain book that Christopher was talking about earlier, and some of the videos that have been suggested as educational pieces for patients, The Brain That Changes Itself has been a really good book to recommend to patients also to help them understand this concept of what I would call self-directed neuroplasticity, or which we as clinicians might describe as perhaps clinician-facilitated neuroplastic change. Norman Doig tells a whole bunch of stories in The Brain That Changes Itself about people who had different types of brain damage and who, under the old paradigm, were pretty much resigned to, well, that's the way it is. You know, you're just going to have to get used to it. But whose clinicians that they worked with didn't settle for that and helped them to accomplish significant therapeutic-directed or self-directed neuroplastic change and were able to recover lost functions. He has more recently published The Brain's Way of Healing Itself. During a interview in May of 2015 with Australian journalist and broadcaster Mark Colvin, Doig, while discussing chronic pain, made the statement that in his view, chronic pain was basically plasticity or neuroplasticity gone wild. And so this is kind of my segue from general neuroplasticity history into looking at some of the applications or mechanisms of neuroplasticity as it applies to chronic pain. So we're going to bring pain into the picture. But before we get totally into that, I do want to give a little shout out to a couple of my heroes in terms of my understanding of how to work with patients with pain before I ever really learned much about neuroplasticity or explain pain or neuroplastics, which I'll talk about in just a little bit or a little bit later. One of the early things that I learned about was this thing called the gate control theory of pain. And I suspect most everybody in the room is familiar with the gate control theory of pain, but if not, it was introduced by Ronald Melzack, who was a psychologist, and Patrick Wall, who was a neuroscientist, in an article they published in Science in 1965 entitled Pain Mechanisms, A New Theory. So back in 1965, we got this new theory of pain that we called the gate control theory of pain. And basically it holds that there's gating mechanisms in the spine in these nociceptive pathways that are influenced by both bottom-up processing and by top-down processing. So to elaborate on that just a little bit, if you're not familiar with this, one of the early teachings that I guess I had when I was learning about the anatomy and physiology of pain was that there's two types of primary pain fibers. You got your C fibers and you got your A delta fibers. And sometimes when you hurt yourself, you might rub on a body part and you'd stimulate a different type of nociceptor, a different type of fiber that's called an A beta fiber. So the A beta fiber is sensitive to touch, but it's not sensitive to noxious stimuli, at least not under normal conditions. So when you rub that injured body part, you're stimulating that A beta fiber. That's bottom-up processing that goes into the spinal cord and has the effect of closing the pain gate. But these pain gates are also closed by top-down processing. And that's any of a wide variety of things like memories, expectations, fears, and so on and so forth. So Melzack and Wall said there's this gate, Melzack and Wall said there's this gating mechanism in the spine that opens and closes based on input, both in terms of bottom-up processing and top-down processing. If you ever wanted to explain to a patient why a TENS unit works, the theory behind a TENS unit is that it activates those A beta fibers. And so that causes a masking of the activity of the A delta and the C fibers. So it's a TENS unit is a bottom-up way of closing the pain gates. But a lot of the things that we do in mental health or in behavioral health and working with patients is try to teach them skills that they can use that will activate top-down processes for closing this pain gate. Now, opening and closing the pain gate and the existence of the pain gate is not really neuroplasticity, it's just structure, it's just the way it works. But it lays a nice sort of foundation for bringing in the discussion about neuroplasticity when you're talking with patients. And so I've included this third bullet point here that says neuroplastic changes can reset the threshold for opening and closing the pain gates. I don't know if Melzack and Wall ever thought about it that way. I don't think they probably said that. I just said that. I put that bullet point in there. But we know it's true now. We know that a lot of these neuroplastic changes that we're talking about have that effect of resetting or recalibrating the opening and the closing of this pain gate. And a lot of the mechanisms that we're going to be looking at in just a minute will help to explain exactly how that happens. So, with a little bow to Ron and Pat, we can ask, what have we learned about neuroplasticity since the publication of the gate control theory? Well, okay. Let's take a second and let this slide sink in. This is a little sort of overview slide that touches on or describes many of the mechanisms of neuroplasticity that we're going to talk about for the next 20 minutes, half hour, something like that. We're going to go through each or most of these things anyway in a little bit more detail. We won't dig too deeply, but I'm going to do my best to try to describe and illustrate what each of these things are so that everybody has a reasonably good understanding of what these mechanisms are. Let's see, before I start digging into that, though, I do want to credit the source of this image. I just love this image. It's one of my most favorite teaching images, and I found it in an article published in the Journal of Clinical Investigation in 2010 by Osipov, Dusor, and Porika, if I'm pronouncing their names correctly. The title of the article was Central Modulation of Pain. And so this is an image that they used and referred to repeatedly to illustrate the concepts they were talking about. And I want to introduce a little bit of jargon for people who might be unfamiliar with a few of these terms because I'm going to be using them going forward today. And this slide will help me to do that. So obviously, we've got a slice or a section of the brain here. And these are sections of the brain stem. And this is a section of the brain, the spinal cord a little bit. It could be in the cervical region, could be in the lumbar, but it's in the spinal cord. And what you can see here are two pathways. And I am going to call the red pathway the nociceptive pathway, at least for right now. We could also, for the sake of talking to patients, if we're using a similar diagram, just refer to it as the on circuit. I'm trying, I think it's a good idea, and I think a lot of people would agree, to get away from describing this as a pain pathway. Because the current modern understanding of pain is that pain does not arise in the periphery. It does not even arise in the spinal cord. Pain is a phenomena that arises as a result of processing of sensory stimuli by the brain. And so it's real easy to refer to these things as pain pathways, but it perpetuates a mistaken notion of how pain is actually generated in the human body. So the technical term is that it's a nociceptive pathway. And this is a first-order nociceptor, this peripheral nerve. This nerve inside the spinal cord and up through the brainstem is a second-order nociceptor. And then up here in the brain, there's also nociceptive networks and circuitry. And so these are third-order nociceptors that are illustrated up here. So it's really kind of, it's overly simplified, but you could say that there's 3 stages of nociceptive or noxious signal processing in the human body. The first is the peripheral nerve, which is the first-order nociceptor, or the primary afferent, it's also called. The second is the second-order nociceptor, or the secondary afferent, it's sometimes called. And then the third level is in the brain. So that's the nociceptive pathway, or the on circuit. There's also the green line here, which illustrates top-down processing. And this goes by all kinds of colorful names. I guess my favorite one is descending inhibitory nociceptive controls. I got that backwards. Descending nociceptive inhibitory controls, or DNIC. Sometimes you'll just hear it referred to as the descending inhibitory system. I think it was Lindsay that referred to the descending inhibitory system during her lecture. She was talking about how we teach people coping skills, and that has an impact on the functioning of the descending inhibitory system. I'm paraphrasing what you said, but I think that's about right, wasn't it? Yeah. So again, what we're talking about is exactly how does that work? I mean, it's kind of cool to think that that works that way, but is there any science that actually supports that? And the good news is, yeah, there's a ton of science that supports that. So we'll be looking at some of that. So anyway, the brain will send signals down through this descending nociceptive inhibitory control system, right back down here to the spine where there's a junction with the nociceptive, or the on circuit, and that's where the pain gate is, or at least that's where the pain gate that Melzack and Wall conceptualized was. I really think now when we look at the whole system that there's pain gates all throughout the system. I think this is a pain gate right here too, because there's interneurons connecting the two systems right there. There's a pain gate as well. There's another one right there. And there's probably pain gates even in the thalamus and even in the cortex, really, if you think about it. But Melzack and Wall were really talking about this spot right here in the dorsal horn of the spinal cord. Okay. Yeah, so that's the jargon. I'll be using some of those terms repeatedly as we go forward, so I thought it would be good to just touch on that. So let's start our survey here with the peripheral nervous system, with peripheral plasticity. And we can start by thinking sunburn. This is the simplest thing in the world, but it's a great teaching tool for patients. Just think sunburn. Anybody ever try to explain central sensitivity to a patient? It's kind of a hard conversation to have, really. They just glass over and they give you this look like, what in the heck are you talking about? Unless you've got good metaphors. And I think a really good teaching tool for central sensitivity is to talk first about peripheral sensitivity. So these guys got a sunburn. As the image shows, in the case of peripheral sensitization, there's a variety of factors that result in the release of this sensitizing soup of chemicals, which reduce the threshold for activation of those first-order nociceptors. So all that red skin is peopled or populated with all kinds of first-order nociceptors that have been sensitized by the fact of the burn. Now, those nociceptors would normally not experience all kinds of sensations as being painful. It would not send a signal to the brain that would say, there's something bad going on here and cause the brain to create the experience of pain. But when those nociceptors have been sensitized by a sunburn, then all kinds of things that normally would not be painful start to be experienced as being painful. Just think what a normally, well, you don't have to raise your hands. I took a nice warm shower this morning, but how would these guys have liked that nice warm shower? They would not have liked that. Normally it would feel great, but because the system has been sensitized, they experience way more pain than they normally would. So we have this sensitization that occurs even in the peripheral, and we will see that sensitization is a form of neuroplasticity that occurs in the spinal cord as well. But before we get to the spinal cord, a few more elements in the periphery. So there are nociceptors in the periphery that are known as sleeping or silent nociceptors. For any of our guests here today who are not Montana natives or who haven't driven Interstate 15 from Helena towards Great Falls, you might not recognize the skyline there, but this is actually an image of a notable Montana landmark called the Sleeping Giant. And so you can kind of see the face over on the right-hand side of the screen and the chest more towards the middle. And it's just kind of a nice picture. I like it. And I thought I'd use it because I couldn't find anything better to illustrate the idea of a sleeping nociceptor, because these sleeping nociceptors also are kind of like sleeping giants. So what they are is they're these first-order afferents. They're out in the periphery, and they're normally not responsive to noxious stimulation. But they can become activated, and they often do become activated after a person has experienced some sort of an injury. And so it's like they wake up and all of a sudden they become sensitive, or they start sending signaling, noxious signaling towards the brain, even in response to non-noxious stimuli. So for example, if you've cut your finger and it gets a little bit inflamed, and so you've got these red parts on either side of the injury, you can touch your finger where it isn't actually injured, and it's still going to be very painful because of that inflammatory process waking up those silent nociceptors and basically turning them into active nociceptors. A third form of peripheral plasticity, and one we'll see again and again at each level of the nervous system, is neuronal sprouting and pruning. And again, I don't have a real good image for that, so I just picked a picture of a tree. Because I think a good metaphor of it actually is in the spring, not too long ago here in Missoula. We saw all the leaves coming out on the trees, and it's just a wonderful sort of thing. And in the fall, they'll dry up and fall away. And so this annual blooming of these leaves and then withering and falling away of the leaves is kind of a metaphor for this process of neuronal sprouting and pruning that is constantly going on in the human body. The figure I have, I can't remember, one of our earlier speakers, I think it was Dan. Dan said that there were 100 billion nerve cells in the human nervous system. We'll go with that number. That's all right. That works good. What he didn't say was many of those nerve cells are capable of making up to 1,000 connections with other nerve cells. So you got 100 billion nerve cells. They can each make 10,000 connections with other nerve cells. You got trillions and trillions and trillions of synapses throughout the human body. And as we said in the beginning, we now know that we're constantly growing new connections between these synapses. We're constantly creating new synapses. If you have one nerve cell here that can have 10,000 connections and one nerve cell here that can have 10,000 connections, today, these two nerve cells might not be connected to each other, but tomorrow they might be. And if you practice whatever it was that caused that connection to occur, you will strengthen that connection. And so that's another form of neuroplasticity. And then if you quit playing that instrument or you quit doing that skill, whatever it is, as time goes by, that synaptic connection may wither away again. There's literally millions of these types of synaptic connections forming and going through a process of atrophy every single day in our lives based upon our experience, based upon our activities and the things that we do. Now, this happens in the periphery, it happens in the spinal cord, and it happens in the brain. So this is a form of plasticity that occurs on all three levels. And so you'll see we'll come back to this slide a couple of times. But in the periphery, there's a couple of interesting aspects of how this works that basic science has illuminated for us. One is, and they both have to do with the sympathetic nervous system. This problematic sympathetic nervous system apparently likes to send out these sprouts to places where they're not supposed to go. And so sometimes when people have arthritis in their knees, what will happen, or in various joints, the sympathetic nervous system kind of infiltrates and sends sprouts into the joint synovium. And then what happens is when you get yourself worked up, you get your fight or flight response turned on, your joint pain increases because the sympathetic nervous system has innervated those joints. It also happens in the dorsal root ganglion, which is the little bulb outside of the spinal cord where the nerve root comes out. The sympathetic nervous system also infiltrates what are called basket cells around those sensory neurons in there. And so again, when you get yourself worked up emotionally, you get your fight or flight response turned on, it can stimulate those sensory neurons that are supposed to be getting information from when you drop a rock on your foot or something like that. But instead, you just get yourself worked up emotionally, and the system sort of gets activated from inside because of the sympathetic nervous system. These are components of what are, or this latter one anyway, is thought to possibly be one of the mechanisms between complex regional pain syndrome. As many people know, complex regional pain syndrome until a few years ago was called reflex sympathetic dystrophy because they thought there was much more of a role of the sympathetic nervous system in that disorder. Now they're kind of doubting whether the sympathetic nervous system is all that important or whether it's the whole story, but it still may be part of the story. And I guess, frankly, we still don't really know the whole story when it comes to that particular disorder, or a lot of pain disorders, actually. Okay, so that's the periphery. Let's take a look at how plasticity manifests itself at the level of the second order nociceptors, or in the spinal cord itself. So we're traveling from the periphery inside the spinal cord. We're in the dorsal horn of the spinal cord where that first order afferent synapses with the second order afferent. That second order afferent then is going to travel up through the spinal cord up to the thalamus in the base of the brain, or in the center of the brain. So that's what we're talking about, is inside the spine right now. One aspect of neuroplasticity that's discussed with regard to the second order nociceptor, or this secondary afferent nerve, is called windup. And this is a progressive increase in the firing of the second order neuron in response to high frequency stimulation from the peripheral nerve. So if you do something that stimulates your peripheral nociceptor pretty intensely, then the nerve that's in the spinal cord might become kind of hyperactive. And it may continue to be hyperactive even though the peripheral stimulation is dampening down. Now, this really represents a precursor to another type of neuroplasticity we'll talk about that's called long-term potentiation. And so this windup is kind of a short-term version of plasticity. And if it becomes more well-established, as we'll see in a minute, we call it long-term potentiation. But kind of the interesting thing about windup that's useful to know is it's become helpful to people who are in the business of administering painful procedures to patients. So if you're having some sort of injection intervention that's pretty painful, or a surgical intervention that's likely to have significant post-surgical pain, or the procedure itself is likely to be painful, what they have found is that you can offset the likelihood of this windup occurring, and thus offset the development of this long-term potentiation by providing pre-procedure analgesic. So the more comfortable the person is going into the procedure, the less procedure pain they have, the less likely these neuroplastic changes are going to occur that will cause them to have chronic pain after the procedure. And so that's kind of the clinical application of this concept of windup. A second form of spinal plasticity that I want to talk about, and one which also plays a role in peripheral plasticity, although I didn't really talk about it in those slides, is that of a reduction in the threshold for nociceptive neuron activation caused by activation of otherwise inactive NMDA, N-methyl D-aspartate receptors. And so we have to look at this slide to understand this one a little bit. This is the axon bouton, you might say, of a primary nociceptor. And we're in the dorsal horn of the spinal cord right here. So this is the end of the axon of the peripheral nerve. And this is the dendrite of the secondary afferent, or the nociceptive nerve that's inside the spinal cord. And so this is the synapse between the postsynaptic membrane and the presynaptic membrane of these two neurons. And you can see that right here, there's a receptor site that is an NMDA receptor site. But in general, that receptor site is blocked by a magnesium ion. However, if you get an awful lot of high-frequency, real intense stimulation coming from the periphery, that can delodge this magnesium ion. It moves out of the channel and opens up that channel, which then allows for additional glutamate neurotransmitters to be received and to contribute to the activation of this secondary nociceptor. So I don't know if I explained that as clearly as I'd like. I'm going to say it one more time. I'm actually going to read my notes. As the image illustrates, the NMDA receptor is normally inactive and blocked with a magnesium ion. A constant drive of noxious afferent input, however, results in a sufficiently strong depolarization to remove the magnesium block, increasing the sensitivity and the irritability of the postsynaptic membrane. Oh, also interestingly, these NMDA receptors are actually also expressed on the presynaptic membrane and contribute to increased release of neurotransmitter as well. So you can see when this occurs, the synapse basically becomes a synapse which is just much more irritable, much more reactive. It's much more easier to cause it to fire, so that even less and less noxious stimuli out in the periphery can induce an action potential along this peripheral nerve, which then just releases a ton of substance P and glutamate, and because these NMDA channels are now open, the secondary neuron is able to accept more of those neurotransmitters, and it's more likely to fire much more easily. So again, it's just more irritable, more easily fired. Yeah. So I hope that's reasonably clear. I know it's kind of complicated stuff, but I think the picture explains it pretty well. A third form of spinal plasticity is this thing I was referring to earlier called long-term potentiation. Now, this occurs when the first, I guess I'm going the wrong direction here. How come I'm going back? Have I got it backwards again? That's what I'm doing. I have remote control dyslexia. Maybe I have a magnesium deficiency. Yeah. Okay, long-term potentiation. Gosh, did I? No, we were just looking at that. Good. So this picture illustrates the initial state and 1 week later in the development of this concept of long-term potentiation. And so you can see a couple differences between the presynaptic membrane, the postsynaptic membrane. Again, we could say this is the peripheral nerve, this is the axon, this is the dendrite of the spinal nerve or the second order nociceptor. Long-term potentiation occurs when the first of two neurons in a chain, so this is the first neuron in the chain, experiences a period of high-intensity stimulation, perhaps because of some sort of noxious stimulus. Because of this period of high-intensity stimulation, structural changes occur in both the presynaptic neuron, so you can see it's producing more neurotransmitter here than it was here, but also in the postsynaptic neuron. You can see that additional receptor sites have developed as well. And what this does is then the first neuron produces more neurotransmitters, second neuron builds more receptors, and the result is that less and less stimulation of the first neuron is necessary for the activation of the second neuron. And this lowered threshold for activation of the second neuron then can persist for long periods of time, like days, weeks, months, years, after the initial period of high-intensity stimulation of the first neuron has ended. And even after there's no longer any actual noxious stimulation at all. So think about this. You know, sometimes people experience complete tissue healing following an injury, but the site of the injury remains painful, remains tender to them. And so very gentle stimulation out at the periphery still causes the experience of pain. And one of the reasons that may be is because the connection between these two nerve cells, perhaps as a result of this NMDA change that we just talked about and other similar sort of factors, has increased the irritability of the connection between those two nerve cells. There's a variation, I guess you might say, on long-term potentiation that's called long-term depression. And this is a situation where a certain the activity of one nerve cell causes inhibition of the nerve cell that it's connected to. So think about this in the context of dysfunction of the descending inhibitory system. When your descending inhibitory system is working properly, it's sending signaling down to the spinal cord that's saying, close the pain gate, close the pain gate. But if that gets depressed in some way, if something happens to interfere with that process, perhaps through this similar dynamic that we could call long-term depression, that might be an explanation for why the descending nociceptive inhibitory control system sometimes seems to go offline. Now, a fourth type of spinal plasticity is what's called expansion of the receptive field of wide dynamic range neurons. I had trouble finding a good picture for this, and so this picture is actually not really designed to explain this concept, but I think the image does a good job. And so, you know, an interesting thing about these second-order neurons that are in the dorsal horn of the spinal cord is they're also called convergent neurons. And they're called that because they actually receive input from a number of primary afferent fibers. So you might have a wide dynamic range neuron inside the dorsal horn of your spinal cord that receives input from all 5 of your fingers. Now, the peripheral receptive field for that wide dynamic range neuron might focus primarily on your middle finger. And so it's responsible for sending a message to the brain if some sort of noxious stimuli is affecting that middle finger. The rest of the fingers it also receives input from, but it just gets general touch sort of information from those fingers. So it's not going to get activated if you cut those fingers. But what happens sometimes with these wide dynamic range neurons is when you have injured the body part that is represented by the center of the peripheral field, it then spreads, and the peripheral nerves, or the other nerves that are converging on that same neuron, start to become active nociceptors again. And so gentle touch on the other fingers can stimulate the experiences of pain as well. And so what you see is a pattern that's kind of illustrated here. The nerve should really only be getting activated if this part of the rat's hind paw, in this case, is injured in some way. But what happens is with time, any sensation to any part of the larger area that's part of the receptive field for that wide dynamic range neuron starts to be experienced as painful. So that's expansion of the receptive field of the wide dynamic range neuron. Pretty esoteric stuff, but another form of spinal plasticity. Now, a fifth form of spinal plasticity, and one we already saw in the periphery, is that of neuron sprouting and pruning. One particular application to the second-order neurons, though, and really to the descending nociceptive inhibitory control system as well, is the idea that neurons that are involved in the descending modulation of nociceptive signaling might die off in the wake of persistent enhanced nociceptive signaling. So if we go all the way back to the picture of the brain and the slices of the spinal cord and the nociceptive pathway going up to the brain, if that nociceptive pathway going up to the brain is lit up intensely, some authors, Hudspeth in particular in an article in 2010, has suggested that that may have the effect of causing dying off of the neurons that are involved in the descending inhibitory control system. So that's one particular application of this concept of neuronal sprouting and pruning to the system inside the spinal cord itself. So before moving on to the subject of the brain or supraspinal plasticity, and really consistent with this phenomena of neuron death in the descending nociceptive inhibitory control system that we've just been discussing, there's sort of a transitional form of neuroplasticity that I want to mention. It's transitional because it involves both the brain and the spinal cord, or spinal cord structures. And what it is this thing that we've actually talked about a couple times, this dysfunction of the descending inhibitory system or the endogenous analgesia system, or what we might just call the off circuit. So I just want to bring your attention to a number of studies that have been published with regard to this particular phenomena. So Giva and Defrin in 2013 cited a number of studies documenting deficient pain modulation in chronic pain patients. Interestingly, they also documented enhanced pain modulation in athletes. So it's kind of interesting to think about what's happening in that descending nociceptive inhibitory control system inside the bodies of people who have chronic pain versus the bodies of people who are professional athletes. We find if we study people who are professional athletes, we find that their tolerance for pain is much higher than the average person, whereas the tolerance for pain of people who have chronic pain is often much lower than the average person. And one way of understanding why this is the case may have to do with these neuroplastic changes in the descending nociceptive inhibitory control system. And so to get back to the whole idea of how do behavioral therapists or behavioral health providers work with people who have chronic pain, I'll come back to actually a lot of the topics that Lindsay was talking about in the PACT program, especially this coping skills development idea. And this is a hard thing oftentimes to get patients to understand. But hopefully, with the information that we're talking about this morning, we have the tools to be able to explain that a little bit better to a patient. That actually by cultivating improved coping strategies, they affect these neuroplastic changes that we're talking about, both in the nociceptive pathway, by ramping that down, and also by restoring the normal functioning, or even enhancing, like an athlete would, the functioning of the descending nociceptive inhibitory control system. Floor, in 2014, published a study describing findings of reduced connectivity in tracts involving descending pain modulation. In particular, people have talked a lot about connectivity between areas of the prefrontal cortex and deeper structures in the limbic system. So what we find is people, for example, there have been studies looking at the impact of cognitive behavioral psychotherapy on pain experience. And they find that cognitive behavioral therapy is helpful in reducing pain. People who participate in cognitive behavioral treatment programs report reduced pain. If they do MRI studies measuring the density of gray matter in various areas of the brain before and after cognitive behavioral therapy, they find increased density of the gray matter in these areas connecting higher functioning areas of the brain to the more sort of primitive, emotional, amygdala, limbic system types of areas. So that's what Floor's talking about there. And then Hudspeth, as we already mentioned, has talked about how persistent nociceptive input can result in inhibitory interneuron cell death. Okay, so now we'll move on to the final level of neuroplasticity, which is the brain. And again, we see this mechanism of neuronal sprouting and pruning. Happens in the brain as well, probably happens more there than anywhere else, actually. And as I was just saying, it results in changes in connectivity between frontal and limbic regions, may contribute to changes in cognitive control over emotional reactivity to pain. Just think about it. If you have a greater circuitry, more well-established circuitry linking your frontal cortex, which is where you do your thinking, to your amygdala, which is where you do all your emotional reaction, then your frontal lobes are going to have better control over your emotional reactions. You're going to be better able to self-soothe and self-regulate these difficult emotional reactions. We'll come back to this thing with emotional reactions in just a second. I was going to say something about that, but I'll save that. The other thing that's kind of interesting, and I mentioned this earlier, is another neuroplastic finding in studies looking at people who have chronic pain is reduced hippocampal volume. And so the hypothesis that arises out of that is, since the hippocampus is one of the two places in the brain known to be actively involved in neurogenesis and the creation of new nerve cells, and the hippocampus is also known to be intimately involved in learning and memory, what's the implication of that if people who have chronic pain have reduced hippocampal volume? Are they producing less in the way of new hippocampal nerve cells? And how's that going to impact their learning and their memory? And the suggestion has been made that may be why it's difficult sometimes for people who have chronic pain to really kind of unlearn their pain, is because they're not actively generating these new nerve cells that are necessary to develop new kinds of memories about things, including their pain experience. So that's one aspect of this neuronal sprouting and pruning in the brain itself. A second mechanism of neuroplasticity in the brain is the concept of cortical remapping. And examples of this concept so cortical remapping means areas it's like Baki Rita, the neuroscientist, remapping his father's brain so that new parts of his father's brain could take over lost language and physical functioning. The brain's very plastic in that way, much more plastic when we're younger, but it's still plastic that way even when we're adults as well. So examples of cortical remapping come from studies comparing, I think this is kind of a cute one anyway, comparing taxi drivers in London to bus drivers, but also from people who learn to read with Braille, from stringed instrument players, particularly children learning to play the violin, and from jugglers, people who learn to juggle. What all these studies have in common is you get an MRI of these people's brains before they do any of these things, and you have them do it for a while, and you get another MRI of the brain, and you can measure differences in the density of the synaptic connections in the areas of the brain that are used for those particular activities. Now, the difference between the taxi drivers and the bus drivers in London it was hypothesized and shown that certain areas of the brain that are involved in cognitive mapping of one's surroundings were much more well developed in the brains of which? The taxi drivers or the bus drivers? The taxi drivers. Why? Because the bus drivers are always going the same route. The taxi drivers had to learn the whole map, right? Yeah. So that's kind of interesting. So we see increased gray matter density in somatosensory regions associated with persistent pain as well. So there's areas of the brain that are involved in pain suppression, and there are areas of the brain that are involved in creating the experience of pain. So when we look at the brains of people who have chronic pain, the areas of the brain that are involved in processing the experience of pain show increased gray matter. And other areas of the brain that are involved in dampening down or blocking the experience of pain show what has been called gray matter atrophy. I don't know if anybody really knows if it's atrophy or not, because I don't think they usually had a picture of anybody's brain before it was in the state that they call atrophy. It might have been the way they were all along. But the really kind of exciting thing, we'll refer to this study or some of these studies in just a minute, is there are studies showing that those areas of the brain that are involved in dampening down the experience of pain can increase their density of gray matter. Or when I say increasing the density of gray matter, I'm talking about increasing the amount of synaptic connectivity in that area, the number of neurons that are connecting to each other. It's been demonstrated in a number of studies now that there's a variety of sorts of activities, therapeutic activities, that will contribute to increasing the density of these synaptic connections in these areas of the cortex that are involved in dampening down the experience of pain. A third brain plasticity mechanism, and again, one that we've touched on before, is neurogenesis and neurodegeneration. Well, Floor, again, has published articles documenting altered gray matter density in multiple brain regions involving pain processing. I guess that's what I was just talking about. McEwen has demonstrated hippocampal shrinkage due to remodeling of dendrites in the context of persistent stress. And I got flashed the 5-minute thing, caused me to pause for a second there. So I don't know if anybody would argue that chronic pain isn't a form of persistent stress. I guess that's what I wanted to say about that. Mutso has shown decreased hippocampal volume in chronic pain patients, and Rodriguez Racki has shown, or has actually kind of criticized this whole idea of gray matter damage or atrophy. And so there is some controversy with regard to that issue. I'm going to have to go real quick because I got 5 minutes left here, but we'll get through this pretty quickly. Another version of supraspinal or brain plasticity is increased activity in the primary nociceptive areas of the brain. Really, I was just talking about that. There's another type of brain plasticity, which is cortical smudging, just very briefly. That's when people lose the ability to discriminate different parts of their body. So oftentimes when you work with somebody who has pain, you ask them where the pain is, they have a real tough time telling you where the pain is because it's just kind of like in the back. They can't really localize it very well. And it's because in their brain, the different parts of the brain have kind of got smudged together. And you can see that again on MRI as well. I want to take just a couple of minutes, since I only have a few minutes left, to talk about the relevance of this to behavioral health intervention. And so I invoke the image of Freud now, just as I did Melzack and Wall earlier, because we have to ritualistically stay in tune with our ancestors. And I do want to say that there is more to pain-focused psychotherapeutic and behavioral health intervention than merely a focus on the impact of neuroplastic change. Although really neuroplasticity and the neurological system kind of is the bedrock or the foundation that everything else dials back to. It really does. So here is a list of relevant clinical characteristics that I put together some time ago that are things that I look for as a psychotherapist or a behavioral health clinician working with people. These are all things that can affect a person's experience of pain, their adjustment to pain. But if you look at it, and I'm not going to give you enough time to really think about this, but if you had time to think about it, you could probably find a way to say every single thing on that list has an impact on the structure and the function of the nervous system and has the potential to change the structure and the function of the nervous system. Just a couple of these things real quick. Catastrophizing is a phenomenon where people magnify the negative experience of pain. They feel hopeless about it. They ruminate about it. It can be measured using a scale called the pain catastrophizing scale. Functional MRI results have demonstrated negative correlation between catastrophizing scores, activity of the prefrontal cortical regions implicated in top-down modulation of pain. Negative emotions have been shown to be associated with increased activation in the amygdala, the anterior cingulate cortex, the anterior insula. I won't read the whole slide, but just keep in mind the earlier principle we said, if you fire it, you wire it. So if you're having emotional reactions that are affecting the nervous system, the brain in this way, you're hardwiring those things in. It's just like learning to ride a bicycle or to play a musical instrument. Psychosocial stress has been shown to contribute to chronic HPA axis activation and have an impact on central nervous sensitization. Vachon Prasou in 2013 published an article suggesting that prolonged pain may induce long-lasting plastic changes in a person's nervous system. Here's a couple of hopeful things. Semenowitz has shown that an 11-week cognitive behavioral therapy intervention resulted in increased gray matter volume in the prefrontal and somatosensory brain regions, as well as other regions. Zeiden has reviewed literature looking at the benefits of mindfulness meditation for reducing pain, and they have done MRI studies again looking at the impact on the density of synaptic connectivity in these areas of the brain as a result of these interventions. So cognitive behavioral psychotherapy, mindfulness meditation, other meditation-based therapies can be very helpful in terms of helping people move in the direction of self-directed neuroplastic change in the interest of reduced pain. I'll just tell you real quickly about a couple of models that you might look into. I don't have time to go into them. I would call them central nervous system neurophysiological models. A couple of years ago, Michael Moskowitz and Marla Golden came and presented at one of these conferences. They have a workbook which you can purchase and a website that you can go to that has a lot of really actually useful materials, particularly some visual aids. I don't think we have time to click on those links right now, so I won't do that. But also, well, some of their basic principles, the pain's an alarm system produced by the brain, chronic pain's a false alarm. They do focus on the role of unresolved trauma as well, basically from the perspective that it causes this chronic fight or flight reaction in the body. They think that the brain essentially learns pain, and I think a lot of people would agree with them. These are some of the things that they encourage people to do as a part of self-directed, accomplishing self-directed neuroplastic change. Now, Christopher was talking about the Explain Pain program, which I'm going to talk about also in just a second here, but you can see that there's a lot of overlap between this neuroplastics program and the Explain Pain program. They're not exactly the same, but they're probably 85% the same. Then there's that Explain Pain book again, and the other one that I'm showing you right here is kind of their newest product. It's called Protectometer. Don't buy this book if you haven't bought this one, because the first thing you'll discover as you start to read this one, they keep referring to that one. Say, well, you got to go back and look at this book to understand what we're talking about. They have an upcoming workshop in Seattle in December, and I think also in, where is it, Philadelphia? Somewhere else in the US earlier in December. Fairly expensive, but it's 3 days long. Their workshops do sell out if you want to go. It's a good opportunity to see Lorimer Moseley in person, along with a famous pain psychologist, Mark Jensen. So it's going to be a threesome for these workshops. I think I'm going to sign up. Here's their basic therapeutic principles. Just give you a second to look at these. And then their intervention strategies. I'll say with regard to education, Moseley has actually published some work showing that simple single-session educational interventions can have the impact of reducing pain in people who have chronic pain. The identifying DIMs and SIMs, anybody know what a DIM and a SIM is? What's a, yeah, it's Christopher. Christian, I'm sorry. Danger in me. That's a DIM, is danger in me. And a SIM? Safety in me. And the reason that they had the little post-it notes that you can see illustrated there is what they encourage you to do is put these post-it notes up all over the place for DIMs and for SIMs. And the idea is to teach your brain that it's not a dangerous situation. You're trying to re-educate your brain that hurt does not necessarily equal harm. And I'm sure I exceeded my 5 minutes, so I apologize to whoever's keeping time, but I think we got like 15 minutes for question and answers now. Is that correct? Yeah? So if you want me to go back to any of those slides that I just zoomed through in the last couple of minutes, I'm happy to do that. Otherwise, I'm happy to answer any question that I have an answer for. or take any comments for that matter. There's a lot of stuff. Went through it pretty quick. Yes, sir.
I've been in practice 13 years since medical school. I've heard about CBT so many times. Why is it so hard to find people who are trained in CBT?
Oh, gosh.
I know therapists, tons of therapists. I know probably 2 who do CBT.
I'm not sure I know the answer to that question. CBT is, I think a lot of people have a lot of CBT skills, but maybe don't describe themselves necessarily as a CBT trained therapist. Gosh, I just don't have a good answer to that question. I think there's probably a lot of folks in Missoula who would describe themselves as trained in CBT. Are you from Missoula?
Flathead Valley.
Yeah, Flathead Valley. Huh. Yeah. Holly's going to answer that question. Holly, are you trained in CBT?
I am trained in CBT. I'm a psychologist in the community, and I'm at the VA currently. I think some of it is that we just don't do a good job advertising ourselves, and I think even within the network of providers in the community, we don't even know each other. So I think that we could do a better job of that. I think that's a big reason, but I do think there's quite a few therapists trained in CBT, and I agree that perhaps they don't identify as that, but I think it's probably more about not doing a good job networking as a profession, excuse me.
Where are you in the Flathead? So at my clinic, we have 4 counselors, actually 1 psychologist and 3 counselors, all both trained and very experienced in CBT for chronic pain.
And another thing you can do is the Montana Psychological Association. You can contact the association if you would like people to get in touch with you who do consider themselves trained in cognitive behavioral psychotherapy. You can put an inquiry out to the Montana Psychological Association, and the executive director would then send it out on the listserv to the membership. And so people who do have those skills and would like you to know that they have those skills would get in touch with you. Yep. Other questions or comments?
My comment is thank you very much. I think your presentation was excellent.
Well, thank you very much. Well, okay, then I will push the button for the last time.
Welcome back. I hope that was a fun exercise, or at least a chance to converse about ethics and figure out some applied ethics. And hopefully we have some information for tomorrow that we can work on our next, and tomorrow afternoon work on our next exercise. Before we start, there was a red purse that was left in the behavioral room. If anyone left a red purse, it will be out at the front. We'll keep it there. Now I'd like to take the opportunity to introduce Dr. Jennifer Schneider once again. And since we did formalities this morning, we will just get rolling with the presentation. And this is a presentation I've really been looking forward to, and I'm so happy that we have Jennifer here. So thank you very much.
Thank you, Mark. Okay, can everybody hear me in the back? Yes, okay. I want to tell you that I teach a remedial prescribing course. I think I may have mentioned it this morning to prescribers, physicians, nurse practitioners, and PAs who have gotten into problems with their licensing boards and have been mandated to take this course. And before they take the course online, I have them go through a list of like 80 statements, and for each one, check on whether this never applies to them, or they just don't believe this, or sometimes or always. And I'm always amazed by how many of these statements they get wrong. And it actually is a very good beginning to the course, because most of these docs are very unhappy to be there in the first place. And they think they know it, especially the ones who are certified in pain medicine or whatever. And so many of them get so many wrong that it kind of is a weird wake-up call for them. So what I thought I would do, I looked at the schedule for this weekend, and it looked like you're going to have speakers and the specifics of medications and other treatments. I would do something that's less intensive and actually go through some of the worst statements that most people agree to, which are wrong, and just discuss very briefly what the right answer is. So we've got an hour. That means that, we're going to be going till like 6:25, 5:25? Okay, thank you. Okay, so we'll get started. First, I just want to review that although in the media we read only about how terrible those opioids are, the fact is that we have to remember that there is a need for balance. And so we need to support opioids where they are indicated and to do risk assessment and not prescribe them when it's not in the patient's best interest. And this is a quote from Scott Fishman, who's a California pain specialist who's highly respected by the California Medical Board and who wrote a wonderful little book, very small, called Responsible Opioid Prescribing. And so his opinion constitutes mainstream, just so if you wonder. So he's talking here about balance. And it's something that the DEA also says that they believe in. I also want to just make a point that there's a difference between acute and chronic pain. Acute pain is pain that it's an adaptive and beneficial event, whereas chronic pain is pain that has outlived its usefulness and that it no longer serves as a useful warning sign. So that's the difference. It's not just that the pain lasts for X number of days or weeks. It really has to do whether it's useful or it's not useful. You may know that there's some sort of genetic illness that people are born with an inability to feel pain, and those kids get into big trouble because they end up with burns and infections and losing limbs and all that because they were broken limbs because they were unable to feel the pain. So pain does serve a purpose, but chronic pain has outlived its usefulness. All right, here's the first statement, and you can think, you probably won't have time to discuss this, but you can think about whether you agree with this statement. So I'm not going to ask people whether they agree, since I've already started telling you that every one of these statements is wrong. But anyway, you just read it and see if you think that this is true. That the main goal of the chief goal of treating chronic pain is to alleviate the pain. Well, so here's the thing. The actual goals of chronic pain treatment are to reduce the pain, but also, at least as important, is to increase function. If you have reduced somebody's pain from 10 out of 10 to 5 out of 10, which, by the way, is the best you could hope for, a 50% improvement is considered publishable if you just invented some new treatment. So that is a very good result. But if the patient is still lying in bed and doing nothing, you really have not benefited that patient. You have to really focus on function as an important goal. And if the patient's function has significantly improved from your treatment, you document that, and that protects you, but also it shows that your focus is in the right place and that it is beneficial to the patient to continue prescribing, and that is regardless of the dose. All right, here's one that I really like. Patient tells me that one opioid works better for him than another. I consider it likely that he's a drug abuser looking for his drug of choice. And I'm telling you, these are statements that the vast majority of prescribers who take my course, who are educated physicians and PAs and nurse practitioners, believe is true. And most of them think this is true. And here's what I have to say about it. If you have a new asthma patient, another chronic disease, and on the first visit you're doing an initial assessment and they tell you that a Proventil inhaler works better for them than something else, what are you going to be thinking? It's not that they're a drug abuser looking for Proventil, right? You know what you're going to be thinking. Now I don't have to spend time trying to figure out what's the best inhaler for them. That's what you're going to be thinking, right? Because they've had experience with their disease. So you have to understand that we need to step back and quit thinking of opioids as evil, and so that anybody says that this particular opioid works better for them must be a drug abuser. Maybe they actually have had experience with different drugs, and people have genetic differences. And sometimes one drug is better than the other or has fewer side effects. For example, morphine is particularly liable to cause itching. And so someone tells you that they prefer another opioid, well, you ask them why, and they'll tell you. And if it's like itching, well, that makes a lot of sense. So don't automatically assume that these people are drug abusers just because they know for their chronic illness what works best for them. I'm comfortable prescribing opioids for chronic pain only if I can objectively identify the patient's pain generator, in other words, the specific source of the pain. Okay. A lot of people think this is true, and what I have to say to you is, what are the most common sources of chronic pain that we see in a chronic pain practice? Well, how about fibromyalgia, headaches, back pain? How about phantom limb pain? Do you know the pain generator for any of those disorders? No. And so are you not going to treat them because you can't tell the source? You know what % of chronic back pain you can tell what the pain generator is? And I'm talking about after MRI scans and physical exams and everything else. It's about 20%. There's so many structures in the back that most of the time you can't say specifically which one it is. And yet, does that mean we're not going to be treating the pain? Again, wanting a pain generator is kind of the reason why acute pain is so much easier to, prescribers are so much more comfortable prescribing. Because when I went to the emergency room with a fractured femur, nobody would deny me pain medication. You just have to, a 5-year-old could look at that x-ray and say, oh my gosh, this bone is broken in half, and they would give me pain medication. But when you can't identify the pain generator, we tend to be uncomfortable using it. So you have to understand that the patient's word is what determines whether they have pain, not if you can find a specific pain generator. So, yeah, we already talked about that. So your decision-making really has to do with decreasing pain, not specifically on finding the pain generator. Now, let me add, I'm not saying you shouldn't do an assessment to find out what the diagnosis is if you have no idea. I'm presuming that this already has been done or that you're going to order it. What I'm saying is if after all your evaluations and attempts to find the specific source of the pain you can't, that's what I'm saying, that that's not a reason to assume that they shouldn't be treated. Next one, a patient who develops withdrawal symptoms after he stops his opioid medication abruptly is addicted to the opioid. And you can't believe what a large % of prescribers believe that this is true. So what do these people have rather than addiction who've been on? How about physical dependence? All right? There is a, for example, any of you ever had patients on Paxil, paroxetine, who went on vacation, forgot to take their antidepressant? What did they tell you happened? They have like flu-like symptoms. They've got withdrawal symptoms. Paroxetine happens to be one of the antidepressants that specifically, because it's very short-acting, are most likely to cause withdrawal symptoms. Does anybody say, how about prednisone? If somebody's been on prednisone for a month for some autoimmune disease or whatever, and then you stop it, do you stop it right away, totally? No, we know that we should taper it. Why? Because otherwise they're going to develop some potentially very serious withdrawal symptoms. And the solution is simply to taper rather than stopping suddenly. Do we say that those patients are addicted to prednisone or to Paxil? No, right? They are physically dependent, and there's a very big difference between those two things. It happens that certain drugs like opioids have both physical dependence and addiction. And I strongly recommend when you are charting, when you are writing in the patient's, well, not writing anymore, typing in the patient's record, and you want to make a point about the fact that that they've been on the drug for a while and so they shouldn't get off of it suddenly, don't say they're dependent on the drug. And the reason is that drug dependence in the DSM-4, the previous version of the Diagnostic and Statistical Manual of Mental Disorders, they didn't like the word addiction because it was too pejorative. Instead, they used the word dependence. So if you look up in the DSM-4 for what they call a heroin addict, you're going to read in there that their diagnosis is that they're opioid dependent. That's the word they used. So what that means is if you write in the chart that they're opioid dependent and your intention is to talk about how they're physically dependent, the next person who reads that chart is going to assume that this person is an addict. And that's, A, shows that you don't know what you're talking about, but also it shows that you're being very unkind to the patients because you are stigmatizing them for no reason. So here is what addiction actually looks like. It's now called in the DSM-5, in the version that came out in 2013, it's called opioid use disorder. And if you look at the criteria for it, of which if you read it, you have to have at least 3 out of 7 or whatever, they boil down to 3 elements. 1 is loss of control. 2 is continuation despite significant adverse consequences. And 3 is obsession or preoccupation with obtaining, using, or recovering from the effects of the drug. That is the criterion, that is the definition of any addiction, and that also relates to behavioral addictions, not only gambling, for example, not only drugs. So that is a very different thing from physical dependence, which is defined as meaning that if you stop suddenly, you're going to develop withdrawal symptoms. It just means that your body has become adjusted in some ways to the drug so that when you stop and then you have to reverse those adjustments that the body has made, that's what the withdrawal symptoms consist of. Okay, number 5. I anticipate that I will need to gradually increase the patient's opioid dose because of tolerance to the drug. You know, I'll bet you if I actually asked you to raise your hands if you believe that people develop tolerance to the pain relieving effect of the drug, most of you are going to think that that's true, and it's false. So I want to speak for a moment about the issue of tolerance. All right, first of all, this is kind of a tricky question because you can't say develop tolerance to the drug. You have to talk about what specific effect. Opioids have several effects on the body. One of them is the one we want, which is pain relief, and the others are ones we don't want, which is the sedation, the constipation, the respiratory depression, which is related to sedation, and the nausea. And then there's, of course, a 5th one, which addicts want, which is the euphoria. So there's 5 of these, but 2 of them they don't develop tolerance to. And that is the constipation, and that's why you have to discuss an ongoing bowel program with them. Too many patients who have not gotten a discussion about constipation come back and they say they don't want to continue the drug because they've developed constipation. And by the way, an addict will never say that. I mean, you know right there that this person is not an addict because they would never turn down a prescription on the basis of constipation. So, and you know, everybody knows that you develop tolerance, thank heavens, to the respiratory depression, the sedation, and the nausea. I mean, otherwise people wouldn't want to be willing to take that drug. But because they develop tolerance very quickly, you start at a low dose, a dose that you might be sure is too low to give them adequate pain relief, but you want to make sure that they're not experiencing these side effects. And then after a couple of days, you can increase the dose, and that way you can titrate it up to where they get relief. And that's why often you end up increasing the dose in the first few visits because you have to start low because you don't know what's going to happen with these side effects. So let's see. Let's talk about when you actually have to increase the dose. You know, we've all had patients that ended up increasing the dose of the opioid, which people wrongly assume is tolerance. So initially, we just talked about this. You have to start low because of side effects. So you are going to be increasing the dose initially. But then what happens is later on, you may have to increase the dose because of disease progression. So if you've got osteoarthritis, if you've got cancer, you know, various diseases, people are likely to get worse with time. So a year later, if somebody says that they need more, they have more pain, don't assume that they've developed tolerance after a year when tolerance to respiratory depression, to sedation, to nausea happens within days. The chances are a year later, it's because they've had some disease progression, or of course it could be some unrelated new source of pain, but more likely disease progression. So you have to really understand this. And I can tell you in my practice, if you talk to any doc like myself who spent years treating patients with between low and high doses for a long time, and I have a published paper on this of 195 cases who were on opioids for an average of 5 years. The majority of them were on the same dose, whether it was low or high. In other words, they did not develop tolerance So it's a mistaken notion that you can anticipate that you're always going to be increasing the dose. So just to review that, tolerance to pain relief with opioids is uncommon, and patients stabilized on a given dose of opioid typically continue on the same dose for years unless there's a change in their underlying disease process. All right, here's the next one, and there was some big hullabaloo in the LA Times about this a couple of weeks ago. Patient who complains that his twice-a-day sustained-release oxycodone, which is OxyContin, or the sustained-release morphine, MS-Contin, which is supposed to be a twice-a-day dose. So if the patient complains that that dose only lasts for 8 hours, or that his Duragesic fentanyl patch only lasts 2 days, they are more likely a drug abuser. So a couple of people are shaking their head, which is good. And the rest of you should be shaking your head, because the fact is the manufacturers of these drugs have made it known to people that about 25% of patients on OxyContin or MS-Contin, it lasts for only 8 hours, and a fentanyl Duragesic patch lasts for 2 days. So this is not necessarily indicative of drug abuse. It just happens to be a reality with the formulation of these sustained-release drugs. Because what really matters is the formulation, the fillers that they put in there to try to slow down the release of the drugs into the system. Next one. If a patient's urine test contains an opioid I didn't prescribe, or doesn't contain one I did prescribe, I decline to continue prescribing opioids for him. I have had phone calls and emails from patients who've been fired by their doctor because, for example, they were on a fentanyl patch and some immediate release oxycodone, Percocet for breakthrough pain, and the doctor ordered a urine drug screen. It came back negative for both of those, and so they got fired. Do any of you believe that this is wrong, that there may be some other explanation? Just raise your hand. Oh, I see about 10 of you do, and the others think that this is right. So let me just educate the rest of you. The fact is that there are several reasons why you might not find a drug that you think you should, or you might find a drug that you think you shouldn't, all right? And I'm going to tell you what they are. First of all, several opioids have metabolites that, if you test for them, are going to appear in every urine drug test. For example, oxycodone, which is in Percocet, is metabolized to oxymorphone. So if you do a urine drug test where you're testing for various opioids, oxymorphone is now available, as it's on for many years, as Opana. It's a different opioid. But the fact is, anybody that's been on oxycodone, when you do a urine drug test, you're going to also find oxymorphone. It's a metabolite. If a patient is on a codeine product, you're going to find morphine in the urine every time. All the codeine codones, hydrocodone, you're going to find hydromorphone. So you have to, if you don't understand why a drug appeared in the urine, it is your responsibility to, you or somebody in your office, call up the lab and ask for an explanation. And some of the specialty labs, it's all printed out on their report, but if they aren't, if it's just a general lab and you don't know, you better find out. To assume the worst and fire the patient is unethical and unfair to the patient. Another reason why it may not appear, if you are prescribing immediate release oxycodone, let's say Percocet, for breakthrough pain, and you tell the patient for breakthrough pain they're supposed to only take it as needed, and it's been 2 days since they took the last dose, you are not going to find it in the urine. Not because they sold it, diverted it, but because they haven't taken it for 2 days. So this is the reason why every time you order a urine drug test, before it's sent out to the lab or whatever, you do it yourself in the office, you need to ask the patient or have your staff ask them, when was the last time, the day and the time, that you took every one of those drugs that we're concerned about, and write it down. And that way, if it comes back from the lab 2 days later showing that it isn't in there, you don't then call them up, because if they did sell it or give it away or whatever, and they're smart, they're going to think, why am I being asked? And then they're going to make up some explanation. You want to get an answer from them before they think that you're going to be suspicious of anything. So you have to get it, every time you get a urine drug test, you need to ask when they last took it. So in addition, now in answer to that question that I said, that fentanyl And oxycodone, as well as several other drugs that are semi-synthetic or synthetic, that are not natural opiates, that are called opioids, in other words, they do not appear on the enzyme immunoassay screen. They only appear on the GCMS follow-up. So if you are doing a dipstick in your office, you are not going to find anything other than morphine and its immediate derivatives. So again, if a patient is supposed to be taking certain drugs, you have to make sure, I would recommend that you put on your lab slip a list of all the drugs that you're looking for, and the lab will then automatically do the appropriate tests to actually find out if this is in their urine. You know, too many prescribers that I know of, they've heard that you're supposed to get a urine drug screen, so they get it, but then they don't understand that that's only the beginning, that's only the first step. They have the ethical obligation to follow up anything that appears on the report that they don't understand. See, we already did this. Okay, next one. If a patient violates their written opioid agreement, I decline to continue prescribing opioids for them. And, you know, I want to tell you that I really believe that there's too much black and white thinking when prescribing opioids. There's too much of a tendency to say you're fired or I'm through prescribing. When something unusual happens and they have you know, broken their agreement, it's what I call the start of a conversation. By the way, all the answers are in white, and if you haven't noticed, and the false statements are in yellow, okay? So anything that's in white is, you know, my answer to those. So every unexplained event should be the start of a conversation. So you want to ask them about why. I mean, there may be explanations that maybe you don't want to find them. I'm thinking of, I had a husband and wife, elderly couple, who were my patients, and one of them was on morphine, and one of them was on oxycodone. And so I happened to get a urine drug screen, and they both, and it turned out that both had both drugs in them, which is, of course, you know, really bad, right? So if you're thinking in black and white, you're going to fire them. But I said to them, you know, can you explain to me what happened? So they said, well, you know, we went on an out-of-town trip one day, and, you know, my wife forgot to take her pills, and I had mine, and so it was time to take the pill, and so I gave her one of mine. So then when we got home, you know, she gave me one of hers to make up for it. This is what happened. So, I mean, is this a reason to fire them? Well, you know, if it's a recurrent pattern, okay, but like a one-time thing, this led to my telling them, you know, it's actually illegal to be using opioids that were not prescribed to you, so please don't ever do this again. And they would say, oh my gosh, I had no idea, you know, this kind of thing. So I know they signed an agreement where it says they don't do that, but, you know, they signed the agreement 6 months ago or 2 years ago, which, by the way, is why I always had my patients sign a new agreement every year, and I would Xerox a copy of it after they signed it and tell them to take it home and review it. All right? So let me continue here. Okay. Patient who says that their immediate release oxycodone helps them feel calmer and more relaxed, and says that oxycodone IR, immediate release, is the only opioid that works, is describing addiction. Well, it's certainly describing something we wish wasn't true, because we don't think that this is our purpose of prescribing these drugs. But the fact is that oxycodone in particular is very effective for anxiety, and that a lot of people do experience these effects on the brain, which are separate from the pain relief, and they believe that it's all part of the pain relief. They don't understand that this is a separate thing in the brain, and so when you switch them to another drug, indeed, they don't get that. So that doesn't mean that they're an addict. It means that they've got some behavioral health issues that may need to be looked into, like, you know, let's look into their anxiety or depression or whatever that these drugs are helping them with. So don't automatically assume that people are an addict in the same way that if they say that their one drug works better than the other, you know, don't automatically assume that they're a drug abuser. So as I said before, this is more likely that they're treating their anxiety. Here's another one. it's incredible how many people think that this statement is true. I prescribe opioids to people who are able to manage them safely, all right? People who are of normal intelligence, don't have organic brain syndrome, and don't have any significant psychiatric illness. In other words, all reasons why they might not be able to take their medications reliably. What do you do with those patients? Well, here's a suggestion. In fact, here's what you should do. Somebody, an old person with dementia, who's bringing them into the office? Their daughter, you know, spouse. So you get the spouse or the daughter, you identify some reliable person. Of course, you risk that, of course, the person who's dispensing it is going to misuse it or whatever, but then these things aren't black and white. But the point is, if you can pinpoint someone reliable to dispense the medication, then you can continue treating the person, because why should someone who's an older person who also has some organic brain disorder or schizophrenia or something, so they can't reliably take, do those people deserve not to get treated for their pain? Well, not if you can figure out a way to do it safely, have somebody else do it. Okay. A patient who has pain and legitimate pathology deserves to be treated with opioids even if they're non-compliant with physical therapy, exercise, referral, smoking cessation, and keeping appointments. You know, doctors get into trouble in situations like this because they say, well, how can I not prescribe for this person? They're in pain. Well, the point is, the big picture is that it is in the patient's best interest that you continue prescribing long-term opioids only if the patients do their part, all right? And that may include all the things that I just listed. Because the thing is that with too many of these complex patients who have all these behavioral health issues, if you give them opioids, you may be providing them with just enough pain relief that they lose any motivation to do what is actually best for them. And these are the patients that are not going to follow through on other modalities. They're the patients that are presented in the cases that I was telling you about this morning, that these clinics present to us. You know, what do I do about this patient? They want their medications, but, you know, they're not doing anything else. It is not in the patient's best interest that you keep throwing pills at them if they are not willing to do what's actually going to make them better. Otherwise, nothing is ever going to change. So, as I was telling the group this afternoon, I was asked to consult on a clinic where there had been some overdose deaths among the patients, and it turned out that the prescriber, I reviewed one chart, the prescriber had continued to prescribe to this patient and documenting all the time that the patient was very depressed. The prescriber referred the patient to a psychiatrist, but this was in a small town, and it was going to take months before they could fly the patient out to some, psychiatrist in another city. And meanwhile, she said, how could I not prescribe for him? Well, was it in the patient's best interest? He ended up using the drugs she prescribed to commit suicide. She lost her license. The clinic closed down because they couldn't find somebody else in this small town who knew as much as she did about opioids. 150 other patients couldn't get taken care of. So really, was all of this in the patient's best interest? You've got to look at the big picture. If somebody can't do their part, it's got to be a team effort. If they can't do their part, it is not in their best interest to prescribe. And by the way, don't say to patients, I don't feel comfortable prescribing, because then it becomes about you and how to convince you to do it rather than what's in the patient's best interest. So every time you find those words about to come out of your mouth, I don't feel comfortable, change it to it's not in your best interest. All right, that keeps the focus where it should be. This morning we already talked about ramped up emotional processing, and that's what you get with these patients who all they want is opioids. Here's the next one. I do a complete physical exam on every visit. Well, a lot of people say that. Obviously, Dr. Mentel does not agree. So here's the thing. A complete physical exam is not required in every visit. And in fact, if your state requires some physical exam, you need a focused physical. Just last week, I was reviewing a case. I've looked at dozens of these cases because I do a lot of medical legal consulting, where somebody came in with back pain, And the medical record, under objective in the record, they talked about, their pupils were equal, round, and reactive to light, their lungs were clear, and the heart had a regular rhythm, and their skin was soft and whatever. And guess what was never mentioned in this extensive physical exam? The back. They were there for back pain. This is useless. And the reason for that, I hate to say it, I'm being cynical, is upcoding. If you have a detailed physical, whether it's relevant or not, you can charge for a more extensive visit. But the point is, has it really benefited the patient if you didn't do an exam on the part that they were, there for? So, keep that in mind. So, even if your state requires a physical on every visit, it does not mean a complete physical. I give an opioid prescription monthly and only as part of a visit. I bet a lot of you believe that one. Anybody that thinks that this is not the way to do it? Let's see, 4 people, 6 people raise their hand. All right. So here's the thing. The frequency of office visits depends on the patient's needs. If somebody's stable, you've been seeing them for a long time, do they really need to be seen every month? No. Now, let's say you say that my state requires that every time I hand a patient a prescription, they have to be seen. You still don't have to see them every month. You can give them prescriptions for up to 90 days simply by writing the monthly script, dated today, for a month, but in the body of the prescription you say don't fill until, and then you put another date, like 4 weeks from now, or 8 weeks from now, 9 weeks. And the pharmacy has to honor that. So they can walk out with 2 sets of prescriptions for the 2 months and then follow an appointment for 2 months later. A lot of chronic pain patients, it's difficult for them to get to an office. It's hard for them to walk, they may need a wheelchair, whatever. Do they really need to be seen every month? A lot of times it's because the prescribers mistakenly think they've got to do it that way, and you don't. So it's one thing if the patient's situation has changed, then you want to see him every month, and sometimes even more often if you're switching drugs and this kind of thing. If you're switching a drug, it's not a good idea to give him a whole month of the new drug and tell him to come back in a month. You need to have more frequent contact with them to find out if the dose is appropriate. Switching from one drug to another can be tricky at times, but if you have a stable patient, it's perfectly okay every 2 months. So I advise patients on chronic pain on opioids that they should not drive. Well, I bet you most of you do that. And let me say that patients who are on stable doses of opioids can drive safely, and you need to advise them to avoid driving when they first start the drug or when you're increasing the dose. But once they've been on it for a few days and they're feeling normal, then they're safe to drive. And I can give you lots of references that support that. However, that being said, if you do happen to get a ticket while you have an opioid in your body and you volunteer to the police that you're on drugs, you're surely going to get a urine drug, a serum drug test, and you could get a DUI just because you had an opioid in your system, even if in fact you were not at all an impaired driver. So there are risks. In addition, there are risks career-wise. It's perfectly understandable why a pilot, for example, they're not supposed to have opioids in their system because heaven forbid the plane should crash for whatever reason, and it turns out the pilot had opioids in their blood. It's going to be a financial disaster for the airline. So there's often a lot of things in this field where you've got a difference between what is medically indicated and what is politically indicated or financially indicated. We were talking in our breakout group this afternoon about the problem when the patient can't afford it, or these particular specialties aren't available locally or something like that. So again, there can be differences between what's medically best and the reality of insurance coverage and financial, all these things. So again, it's not black and white. If a patient on opioids reports sedation or constipation, I attempt to reduce the dose. A lot of people said that that's true, but the point is, what happens to their function? Remember, function is extremely important. What's going to happen to their function if they're on a dose that's giving them good pain relief, but you're reducing it because of constipation or sedation. What's likely to happen to their function? Yes, thank you. In the back there, she went like this. They're going to get back to lying in the bed all the time, and you really want that? So it is really better to consider treating the side effects, and that would include a bowel regimen, which you should talk to anybody that's on opioids, and anti-nausea drug, testosterone replacement. I don't know how many of you are aware, I hope a lot of you, that people on chronic opioids, men tend to have subnormal, and I mean subnormal, testosterone levels, and they need testosterone replacement. All men who are on opioids more than for a short time, low dose, should have their testosterone level checked. Stimulants, we use Provigil, modafinil, shouldn't use the trade names. Modafinil, very good for combating opioid-induced sedation. Problem with modafinil is that it's not FDA approved for that indication, and therefore most insurance companies are very likely to not pay because of that. So again, we're talking about financial issues versus what is medically a good thing. I get a urine drug test on every visit. What's the point of a urine drug test, really? Is it, tell me, how long do I have, Mark? What time are we finishing? 5:20? You're doing fine. Okay. I get, so here's the thing. For those of you that haven't thought this through, the purpose of a urine drug test is to find out if there's a drug in there that shouldn't be there, or if there isn't a drug that should be. And if the patient knows that you're going to get a urine drug screen, and they're not stupid, what are they going to do before they come to the visit? Anybody have any idea? They're going to not use the cocaine, right? Or they're going to pop a pain pill, an opioid, because they know they have an appointment with you in a couple of hours. I mean, really, what are you going to benefit out of you doing a urine drug screen from somebody that knows that when they walk in the door, you're going to be doing it? You're much better off on stable patients to do an unexpected urine drug screen a couple of times a year than you are getting it on every single visit. Those urine drug screens are expensive, and they're just not worth the time and the money to do them unless you're doing them in the optimal way. Remember, you want to ask the patient when was the last time they took the dose, the date and the time of each of the drugs that you are looking for in the urine, and then you want to do it in an unexpected way. All right? So, all right, this one is like one of the most important take-home lessons. And the doctors that who take my remedial prescribing course, this is very appropriate to them because they have gotten into problem with their medical licensing board already. So here's the thing. It says here, if a family member calls me, I decline to take the call if I don't have a signed release from the patient to talk with that person. How many of you would take a call if a patient, 3, 4, you know what, I'm so impressed. I think there were like 8 of you that would do it. Well, the point is, and some of you may kind of really be surprised by this, but you all should do it. And here's why. HIPAA rules say you cannot say anything to people who call you if you don't have their permission. It doesn't say you can't listen. So you have to take the call and listen to them. Why? For several reasons. For one thing, in terms of the patient's benefit, which is really crucial, if the family member has something that's important, like, my husband says he's doing fine, but actually he spends 20 hours in bed. You want to know that, don't you? Because obviously we're talking here about function. Or if they call you and they say, my son is buying stuff on the street, do you really want to continue prescribing for him in that case? So you really want that information. Part of the due diligence that we have to do as opioid prescribers is to have as much information as possible. It's who said it, trust but verify. I forget who said that, but anyway. And that's really what you need to do. So, and then the second thing is that over and over again in my remedial prescribing course, I have prescribers who, when I ask them, who turned you in? You know, why did the board go after you, or why are you being sued? They say that, or I read it in the record, in the complaints and all that I get from the board, that it was a family member who turned the doctor in, who complained to the board. Why? Because the family member says in their complaint, I tried to tell the doctor, but he wouldn't talk with me. So, you know, you are risking yourself, as well as the patient's safety and best interest, if you decline to get what could be very useful information. So, you know, please take that home as a major take-home lesson for today. The family, you have to consider them as an ally, not a foe. All right? So, okay. Here's another important one. I get annoyed with pharmacists who call with questions regarding the patient's prescription. All right? So, you know, we're all busy, and yeah, it's annoying if a pharmacist calls, but here's the thing. By law, pharmacists are responsible for prescriptions that they dispense. And so their primary concern is the patient's safety. So they are obligated to do what they can, because if they fill a prescription that they believe has some issues, whether it's drug-drug interactions that they know about that you didn't apparently consider, or whether they think that the conversion from one drug to another that you did was wrong, and in fact I had a case where that exactly thing happened, who do you think is going to get sued if there's an adverse effect? Not only are you, but the pharmacist will get sued too. So they've got to protect themselves. So the point is, and by the way, the other thing that you are at risk for if you don't talk to the pharmacy, I had somebody taking my course who is a dentist who had prescribed an antibiotic for a patient, for someone who was not a patient of his, but they were going on one of these missions, a medical mission in Africa. And so this somebody else who was on the mission called and said, you know, I just read the instructions and I'm supposed to be on doxycycline for prevention of malaria, and I didn't notice it until tonight, so, you know, can you call that in? And the doctor said, sure. The dentist said, sure. He calls in the doxycycline. The pharmacist challenged him and said, well, why are you prescribing doxycycline? I guess dentists don't usually use that drug. I mean, it's just a tetracycline. It's nothing, right? So the physician responded to the dentist responded to the pharmacist in not a very nice way about being challenged about prescribing an antibiotic. And what did the pharmacist do? Turned him into the board. What happened to that dentist? He had to take a 21 CME expensive prescribing course because of that opioid prescribing course, which did he really need for his career? No, but you know, what I'm saying is you have to be nice to pharmacists. They can, well, but I mean, that's unusual, but the main thing is pharmacists know more than anybody else conversion, what's safe, conversion ratios from one opioid to another, side effects. They can be real allies to you. So you have to consider them team members and always be willing to talk to them. We already talked about this. Don't put in the chart that they're opioid dependent unless you want to say that they're an addict, all right? So what happened? Okay. So I want to repeat this because it's really important, that opioid dependence is the DSM-4 term for opioid addiction. Don't stigmatize the patient by writing in the chart that they're opioid dependent when you mean that they're physically dependent on opioid. Take the 2-3 extra seconds to use the word physical. All right, and this is just something that I haven't read, but that has always bugged me when I review medical records for legal purposes, which is you probably all use the SOAP format still, even though it's now all electronic, which is the subjective, what the patient tells you, the objective, what you have noticed, the assessment, which is your thinking about it, and the plan, which is what you're going to do. So over and over again, I read medical records where the assessment part gives you the ICD-10 code. And that is wrong, wrong, wrong. Yes, it's got to be included, I understand. You're required to put in why they're there, like for back pain. But when they came in to discuss their back pain, and your assessment consists of ICD-10, whatever, 54 point, whatever, that's what they came in for this diagnosis, right? This is their diagnosis. This is not the assessment of what they learned in that visit. And you know just about everybody screws up on this. But the point is that the assessment has got to describe your current thinking and conclusions based on the subjective and objective information of that visit. The assessment is not synonymous with diagnosis, and I think most prescribers do not understand this. But I can tell you, when I review medical records for attorneys, what I have learned is the best defense you have is your explanation of why you decided to increase the dose of an opioid or add another drug or whatever. Your thinking has got to be stated on there to explain why you made certain decisions. If you simply are duplicating their diagnosis, which is what they came in for, nobody has any way of figuring out what your reasoning is. So please, go back and look at your records, and if you're guilty, I won't ask you because I have a feeling a majority of you probably do this, it is bad, all right? Start writing down the assessment being as what you learned from that visit. That's why they're there to see you. So is that Dr. Mentel laughing there? Okay. Okay. So assessment is the conclusion based on what you observed and your thinking, and this is for the patient's benefit and yours as well. Okay. Oh, here's another one that drives me crazy. So when you're documenting a follow-up, and it says here, an acceptable and efficient way of describing the patient's current activity is, for example, function is improved by 30%. Some of you are groaning, and I'm glad, because really, what do you know about the patient's functioning from the patient saying, well, I'm 30% improved? I mean, really, what have you learned? Nothing. Nothing, right? What you need to do for your own protection, if you have to defend your decision-making, especially when the patient is on opioids, as well as for the patient's benefit, is what you want to do is you want to document the actual patient's function. And you know what? If your EMRs only have numbers and boxes to check, you need to go and revise them so that you have space to type in or dictate or whatever you do with the EMRs, some actual information. You want to be able to have a picture in your head of what that patient is doing. That means if they say, so for example, some of the things, all right, he now walks the dog 15 minutes a day. That's good. If they say they walk the dog, and this is the first time you've heard this, I suggest your next question should be, what about this situation? What? How about, how big is the dog? I mean, you know, when I picture walking a dog, I'm thinking of my golden retriever that I walk, and I have a neighbor who's got a Chihuahua, and believe me, it is a different kind of exercise. When I see my neighbor, a very macho guy whose wife, who had married fairly recently, had a Chihuahua, and he's walking the dog, you know, from walking a large dog. So if you want to have a picture in your head of the patient's function, you've got to ask them, what size dog, and you know, for how long? Then you know. She is able to have sex. She now spends only 8 hours out of 24 in bed, whatever. And you know, on the first visit, you should ask them about their goals, and you want to have some measurable functional goals and documented. And then when they come back, you ask them about the goals. So this whole thing of writing down % improvement, things like that, are, you know, or from one, you know, that's worthless. It just bugs me whenever I see those. I've prescribed or given controlled or non-controlled drugs to family, friends, and staff. You know, I've taught this course for, this is the 4th year, the remedial prescribing course, and thank you. Everybody has given or prescribed antibiotics to their kids and, you know, stuff like that. We all do it, all right? You're not supposed to do that. We all do it. The problem is it's illegal to prescribe scheduled drugs, but it's kind of not a good idea to prescribe anything. And here's an example. So what about a doctor who gives his wife an antidepressant? Well, you know, why is she depressed? You know, I mean, talk here about what the situation is. You're not going to get things that are necessarily in the best interest of the wife. Maybe, you know, her marriage is falling apart and that's why she's depressed. And if he prescribes an antidepressant for her, now maybe she isn't going to go get help. And I actually had a friend who was married to a psychiatrist who was in the exact situation. Her husband insisted on dealing with her psychiatric problems by prescribing because he didn't want her to go to somebody else in their small town, to another psychiatrist, you know? So, you know, think about that. There really is a reason why it's not a good idea to be prescribing for your own family. So the other thing in terms of ethical, we're almost done here, all right? When we're talking about ethical issues in pain, in pain management, patient education is really important, especially when you're talking about chronic pain. So these are some things to consider that you really need to talk to your patients about when they are on opioids or you're starting them. You have to explain to them that sudden stopping may cause withdrawal symptoms. Supervening acute pain requires additional pain medications. How many of you have had patients that went to the emergency room for a broken arm and they were already on opioids, and then the ER doc said, well, you don't need any more opioids? Well, the fact, what, you've had that? I mean, it's terrible. They don't understand that patients, that being on an opioid for chronic pain is not going to protect you against experiencing some other pain. And so they have to be treated. And I tell my patients to call if that happens, and then I document it. I tell them what to, you know, okay, you can take an extra dose, and it's documented because that may mean that their next script is going to be a day early or whatever. Let's see, addiction versus physical dependence. So I think we've talked about that. And if the issue is that they're addicts, then, and if they're active addicts, that you don't want, if they're actually abusing, misusing, whatever, they need to be referred for addiction treatment, and you shouldn't be prescribing opioids for them. If they are, it's a decision. When are they? There are patients who are recovering opioid addicts who need to be on opioids for chronic pain, but you know, somebody who's skilled in that should be making the decisions. Primary care physicians who don't have experience in addiction, people like me, and there's a couple of people here who both have training in addiction and in pain medicine, we can make those decisions and we can assess whether the patient is working an active recovery program and so forth. It's a very tricky thing. It's not something that primary care docs, I think, who are inexperienced should be doing themselves. Okay, so when it comes to red flags, you know, if you don't have to be 100% certain about whether to start or continue a patient on opioids, you don't need absolute proof. But if your gut feeling is that there's a problem, then you can get referral, you can get advice, you can decline to continue prescribing. I want to say that not all bad behaviors have to do with addiction. There are some behaviors that are just as likely or more to be due to undertreated pain, which is something to consider, including going to more than one doctor to get pain medications if they're getting a very small amount only from one. This is very bad behavior, but it could be one that would stop if they were being prescribed appropriately. On the other hand, there are some behaviors that are definitely suggestive of addiction, and you don't have to go any further. For example, how about selling prescription drugs? Why do people sell their drugs? What pain are they treating? Pocketbook pain, you know, and we're not in the business of treating that. Another one is injecting an oral or topical formulation. You know, what causes a person to have euphoria is not the concentration of the drug in the bloodstream. I mean, there are people that are on high doses of opioids. They're not feeling euphoria. It is the rate of increase of that drug in the brain. The faster it gets in the brain, the more you're likely to experience euphoria. That's why people inject their drugs. That's why people smoke pot rather than eating marijuana brownies. You're going to get more of a high. So if somebody is taking their prescribed oral or topical drug and they're injecting it, you know that this is not good. You don't have to look further. So you need to be discerning about figuring out what these bad behaviors mean. So the last slide is you want to position opioid therapy by asking yourself, is the patient making reasonable efforts to take care of themselves? Remember, I said they've got to be a part of the team. Are opioids likely to work well? What are reasonable alternatives? is there moderate to severe pain, and is responsible use likely? And remember, responsible use could mean that someone else is dispensing if they can't. So with that, I will stop, and I think we actually have a few minutes for questions. So, you.
I'll shout.
Okay.
I was wondering if you could cite some sources for the lack of tolerance to opioid analgesia, because that's something that certainly I didn't know, and I don't think that it's common knowledge, and trusting but verifying.
Right. And I can't give you, I mean, I don't have it in my hands, that reference. But if you, I don't know if there's some way to get it to everyone, but if you want to leave a card and write on the back that this is what you want, I'll be glad to email you those references. Next. Everybody's had it, right? No more questions? Okay. If there are no questions, then hey. Oh, there's one more over there. Okay. Yes?
What if you are the only doctor for 500 miles and you don't have specialist training? Are there electronic options now to help people in that circumstance?
I don't know specific electronic ones, but I bet Dr. Mentel knows because he's looking very smiley. I mean, my only thought would be that you find people long distance that you can phone or email to get suggestions. I mean, surely that should be possible. Mark, do you have any suggestions on that?
I'd like to say that there was an exact solution for that. It's one thing we'd like to see more availability of telemedicine, being able to have these availabilities, and I would think that might come out. I was hoping that might come out in some of the ethical questions or solutions we might have for rural states like Montana. How do we get that infrastructure? So, you know, when you're a doc out in a small area, you're the only one there, you have no one to bounce things off of, and having support, being able to talk to someone and see if you're on the right track and be able to go over cases, I think is an important thing. So it is an issue, and I wish I had a solution here in Montana. MMA is trying to look at that, though. I will state that.
Oh, I want to modify my answer to you, sir, which is if you look at my website, which is my name, jenniferschneider.com, okay? I have on the website a whole bunch of articles I've written on various issues with opioids. And look at the one by myself and Ken Kirsch. And it is a review of like 180. At the time that I retired from direct patient care, which I did a few years ago, I reviewed my entire records of all my long-term patients. I had like 188 patients I've been seeing for an average of like 5 years on opioids during those 5 years. And the article specifically talks about tolerance and opioid-induced hyperalgesia, another sort of non-existent phenomenon. Yeah.
So while I appreciate that there are certain groups of patients that do not demonstrate clinically significant
Right.
tolerance to analgesics, I think it's a little, I don't know, I'm going to choose my words carefully. I don't think we can make a broad statement that tolerance to opioid analgesia does not occur, because clinically we
Yeah.
see that it does, even though in a large group of patients in all of our practices, we have patients where it has not.
And I think that this actually is a point that can be disputed. And I have heard what you were saying, I've heard it said by other people. I have not seen anything in the literature to actually support that in terms of any sort of high-quality studies that support that. And there's plenty in the literature about the fact that the majority of patients on these doses just are able to continue it. I think there is a confusion if you don't have very careful studies about whether, about the type of study. In other words, have they ruled out disease progression, et cetera. So there's various issues. So all I can do is, you know, you can look and see the article I wrote, which is now, I think, about 3 or 4 years old. But anyway, basically it summarizes the literature of what was known at that point, and the conclusion was that this was not a common phenomenon. I can't say that it never occurs. Okay. In the back there.
You haven't mentioned anything about the new CDC guidelines.
Yes.
You have mentioned high dose opioid, long-term low dose? I'm curious as to what your opinion.
Well, I haven't mentioned it because that was not part of the talk, but I did actually, if you look up the latest issue of Practical Pain Management, I do have several of us had comments on the CDC guidelines, including myself. And my main concern with the CDC guidelines was it's a rather lengthy article, and most of it has to do with the discussion of the quality of studies that make various points as opposed to actual guidelines for prescribing. So, for example, they have one item says that you should do a urine drug screen, but if you're going to have a guideline for doctors that they should do a urine drug screen, you're going to get into the situation that I run into repeatedly when in medical legal work, which is, or just in my experience of hearing from patients, where so that the prescriber does the urine drug screen, but they don't know about how you need to find out when was the last dose, and you need to call the lab if you don't know the reason, the meaning of the abnormal, unexpected results and all that. And I felt that the guidelines in general were very deficient because, as I say, if you read the entire document, and I think most people don't, they just look at the 12, recommendations. Those recommendations are not real guidelines because they don't tell you specifically how to do it. And really what I was hoping for when I heard that these guidelines were forthcoming, that they would actually tell you what to do. That's what guidelines are, is they tell you what to do, but the urine drug screen one, doesn't. I also felt, I know I'm running a little late, but whatever, I'm sorry. 2 minutes, okay. So I also felt with regard to their statement, now this is supposed to be specifically guidelines for chronic pain, but they had a specific guideline for acute pain, which is not even supposed to be a subject of these guidelines. And the ones for acute pain said that most people need it for less than 3 days, and certainly not more than 7 for acute pain. And really, when you think about it from a practical perspective, somebody has a sprained ankle, let's say, and they come to see you, and 3 days later, you've only given them 2 days of opioids. Now, what do they do on the 3rd day? They can't drive, right? They have a sprained ankle. They come to the office to get another 2 or 3 days, because you are not going to give them more than 2 or 3 days the first time. And, how can you say that as a general rule that it's not going to last more than, it said and never more than 7 days? Yeah, right. Well, you had some, knee replacement, and really is 7 days going to be enough? So I felt that those guidelines were very arbitrary, and that unfortunately, those are recommendations. They're not really guidelines, and they're not based on, what are the facts that acute pain lasts only for a day or two? That, that's not a fact. That guideline was an opinion, and I think it was to the detriment of patients. So with that, because I'm seeing all these signs saying my time is up, I think I'd better stop. So thank you very much.